Hello, my name's Alice. I'm an F1 at Samwell and City, and this mini lecture is on contraception. So we're going to cover the main types of contraception available, and then you should be able to counsel someone presenting for contraception on suitable options for them. And then also you should be able to explain to a patient how to use a condom, which is a common OSCE scenario at Birmingham. So we're going to cover natural contraception, the barrier methods, combined hormonal contraception, the progesterone-only pill, and then the long-acting reversible contraceptions, and then also surgical options, emergency contraception, and a few special patient groups. And then we can go through some cases. So first we're going to consider natural contraception. So the first type of natural contraception is abstinence. It's the only guaranteed contraceptive. And then other natural contraceptives are only really suitable if you're happy to get pregnant and you're in a monogamous relationship because there's no protection against STIs. And these include the rhythm method, where you track your menstrual cycle, including often your body temperature, and then get an idea of your fertile and infertile periods within the cycle, and then time sexual intercourse to the infertile parts of your cycle. It's probably more useful if you're trying to get pregnant than trying to prevent pregnancy. And then the withdrawal method, where the penis is removed before ejaculation. Moving on to barrier methods. So barrier methods physically prevent the sperm from travelling through the cervix onto the uterus and fallopian tubes and fertilising the egg. So options include the male condom. So that's helpful because it protects against STIs, but the failure rate depends on proper use. So with optimum use, the failure rate's only around 2% a year, but average use is around 15% a year. The female condom, which is less commonly used, is also protective against STIs, and it has a similar failure rate to male condom. Other less commonly used forms of barrier contraception include diaphragms and caps. So these cover the cervix. They need to be inserted into the vagina prior to sex, and they need to be left in place for at least 6 hours afterwards. These have roughly a 5% failure rate per year. You need to be quite motivated to use them, so you need to time insertion and removal. You usually use them with a spermicide such as nonoxynol 9. They offer some protection against STIs, but less protection against HIV. So explaining how to use a condom is a common OSCE station at Birmingham. So if you get this station, the key points to cover are for optimum protection against STIs and pregnancy, you need to use a condom every time you have sex. You need to make sure that condom is either British standard or European CE marked. You should check your expiry date and not use it if it's out of date. They're single use only, and don't use 2 condoms simultaneously. It doesn't offer more protection, and the friction between the condoms makes them more likely to tear. You should apply the condom before any genital contact. And then if you're going to use a latex-based condom, you should only use water-based lubricants, because oil-based lubricant can degrade the latex and make them more likely to tear. And then you should remove the condom promptly after ejaculation. So moving on to hormonal contraceptives. So first we'll have a think about combined hormonal contraception. So these contain both estrogen and progestogens, and they come in various combinations of different estrogens and progestogens in different doses. But broadly, they work by exerting a negative feedback loop on the hypothalamic pituitary ovarian axis, which inhibits ovulation, and it also thins the endometrium and thickens the cervical mucus. So the main type of combined hormonal contraception is the combined oral contraceptive pill. So typically you take 3 weeks of a combined estrogen and progestogen, then have a week of either a placebo or no pill, during which you have a withdrawal bleed. You can take the packs back to back to delay bleeding, and if they're used properly, they have quite a low failure rate, so less than 0.2% per year. The main side effects and risks associated with the combined oral contraceptive are due to the estrogen, so you have an increased risk of venous thromboembolism and MI, and this risk is increased with increasing age, with smoking, and with obesity. So you should be cautious in prescribing a combined pill in these groups. There's also a small increased risk of cervical cancer and breast cancer, but it reduces your risk of ovarian and endometrial cancer. So just if you're prescribing a pill, there's advice you need to give to a patient about if they miss pills. This does vary from pill to pill based on the amount of estrogen in them. So it's worth checking the manufacturer's leaflet. But in broad terms, if there's a standard strength pill with a standard dose of estrogen, if you miss 1 or 2 pills, you're okay. If it's a low dose of estrogen, only 1 missed pill is allowed. And if you miss more than your allowed number of pills, then you should continue to take the pack, but you need to use alternative contraception for 7 days, such as condoms. And if you have less than 7 pills left, then you should start the next pack straight away once your current pack has ended, so don't have the pill-free break and the withdrawal bleed. But do check the product advice. If your patient gets diarrhea, then she should continue to take the pills, but follow the missed pill advice as above. And if your patient vomits within 2 hours of taking the pill, she should either take another one or follow the missed pill advice. Also be aware that certain antibiotics can induce the enzymes that metabolize the estrogen. So if you're prescribing these antibiotics, then just check the interactions when you prescribe them. You'll have to advise them to use condoms throughout the course of the antibiotics and for 7 days afterwards. And the other thing to tell their patient is that if they're booked in for any major surgery, they should tell their surgeon and anaesthetist, because they are at increased risk of venous thromboembolism, and most surgeons would advise them to stop around 4 weeks before the surgery. Other forms of combined hormonal contraception include the patch. So you apply your patch weekly for 3 weeks and then have a patch-free week. And apart from that, side effect profile and risks and benefits are quite similar to the pill. And the vaginal ring. So that's inserted for 3 weeks and then removed, and then you have a new ring for the next month. The benefit of that against the combined pill is that there's less systemic side effects because it's acting locally, but apart from that, it's also fairly similar to the combined pill. So just in broad terms, the side effects of the sex hormones. So knowing these, they're fairly generic to all the contraceptives, and it will help you understand the side effects of the various contraceptives available. So the main side effects of estrogen are nausea, headaches, fluid retention and weight gain, and breast tenderness. And then you also get those more serious adverse effects, such as an increased risk of VTE and MI. And then progestogenic side effects include depression and mood disorders, symptoms associated with PMT, so premenstrual tension, irregular bleeding or amenorrhea, which can sometimes be a desired effect, acne, again, breast tenderness, weight gain and reduced libido. So now thinking about the progesterone only pill. So progestogens work by thickening cervical mucus, and they often also prevent ovulation. So the progesterone only pill is taken every day without a break for a withdrawal or bleed. And most of them have to be taken within the same 3-hour window every day, except for desogestrel, which has a 12-hour window because there's a higher dose of progesterone. The failure rate's around 1% if taken properly, but obviously compliance is an issue because of the short window in which you have to take the tablet. But progesterone is particularly useful if estrogen is contraindicated. So if the person smokes, is overweight, as women get older, the risks of VTE with estrogen get higher, and therefore progesterone gets more suitable. So that's when they can be used. Unfortunately, they are reliant on good adherence. And side effects are mainly those of systemic progestogens, as we've just discussed. So now going on to think about long-acting reversible contraception. So these are often preferable methods of contraception because they're not reliant on either compliance with tablets or on remembering to use barrier contraception at every sexual encounter. So the first one we're going to cover is the depot, so it's Provera. So this is, again, a progestogen. It's medroxyprogesterone acetate, and it's given every 3 months, and it can be just given intramuscularly in GP. So the failure rate's quite low, at less than 1% a year, and women tend to get irregular bleeding initially, and then they often get amenorrhea. But side effects can include any side effect associated with progestogens. Other side effects to be aware of is that it's associated with a reduction in bone mass. So they shouldn't be given in teenagers who haven't reached peak bone density yet, or women at risk of osteoporosis. There's also a delayed return to fertility, so if a woman is planning on starting a family soon, this isn't a suitable contraceptive. And then the next Nexplanon implant, so again, this is a progestogen, it's etonogestrel, and this acts systemically as well. So it's the same mechanism of action and side effect profile of any progestogen. It's inserted subdermally, usually into the skin around the bicep, and the failure rate is quite low. It's a very effective contraceptive at less than 1% a year. And the benefit of this over the depot is that there's a rapid return to fertility. And then going on to think about the coil. So first of all, the intrauterine system. So this is either Mirena, Jadess or Levocert. So Mirena has a slightly higher dose of progesterone and will last for 5 years, whereas Jadess and Levocert will only last for 3 years. And they all contain levonorgestrel. So the coil is inserted into the uterus, as you can see in this photo, and it sits in the uterine cavity. So some of its effects are local. So the Mirena and the others have the benefit of reducing menstrual blood loss and period pain. And there's the benefit of having fewer systemic progestogen symptoms because there's less circulating progestogen. You also get a rapid return to fertility on removal and a very low failure rate of less than 0.5% a year. The disadvantages and risks of the intrauterine systems include pain during insertion, and the insertion process often puts a lot of women off the coil. There's a risk of perforation during insertion, and there's a risk of expulsion, usually within the first menstrual cycle after insertion. If women have an asymptomatic STI, there's a risk of PID at insertion because it will help those bacteria to migrate further on into the reproductive tract, but this risk can be avoided by screening for STIs. And if pregnancy occurs in a woman with an IUS, it is more likely to be an ectopic pregnancy. Although pregnancy is so much less likely to occur, there's still a lower incidence of ectopic pregnancy than there is in the general population. And just quickly to go over the mechanism of action, so it is very similar to the other progestogen containing contraceptives. So the progestogen will inhibit sperm from fertilising the egg by disrupting their motility. It will thin the uterine lining to make implantation more difficult, and it will thicken the cervical mucus, which impedes the passage of sperm. The other coil is the intrauterine device, so the copper coil. This has a slightly different mechanism, so it prevents fertilisation because it's toxic to sperm, and it also prevents implantation. It has a very low failure rate, so less than 0.5% a year, so it's another very effective contraceptive. Some of the problems are common to the intrauterine system, so pain during insertion, risk of expulsion, and risk of perforation. The benefits of the copper coil are that it's non-hormonal, so in women where hormonal side effects are bothersome or estrogen and progesterone contraindicated, this can be very useful. The main disadvantage of the copper coil is that it can often cause increased period pain and bleeding. So if a woman already has heavy or painful periods, it's not a very good option. And then having a think about surgical options. So these are male and female sterilisation. So male sterilisation is a vasectomy. So this is where the vas deferens, as can be seen in the diagram on the right, is ligated and a small portion of the vas deferens is removed. And this stops the passage of sperm. You can only rely on male sterilisation, so vasectomy, for contraception once they've had 2 consecutive negative semen analyses. But it's a fairly simple procedure, it's done under local anaesthetic, and it has a much less failure rate than female sterilisation, so lifelong failure rate's only 0.05%. Complications include pain, infection, haematoma around the site of incision, and then failure. And the important thing is to make sure that the patient is certain and they're not going to regret it, because it is possible to reverse, but there's a significantly less chance that you'll achieve a natural conception after reversal of a vasectomy. And then going on to think about female sterilisation. So the benefit of this is that even if you're not in a monogamous relationship, you'll still be sterilised, whereas if it's a male sterilisation and then that will only work if you're in a monogamous relationship. So it's a laparoscopic procedure, and usually clips are used to clip the fallopian tube, which prevents the travel of the egg and the sperm and prevents fertilisation. The failure rate is about 0.5% lifelong, so it is quite effective, but it is quite difficult to reverse, and the chance of getting pregnant after reversal is lower than before. So you need to ensure that someone's certain. So it would usually only be used in older women who've completed their family, or women who have a medical contraindication to pregnancy. And the complications associated with female sterilisation are mainly those of laparoscopy and anaesthetic. So the anaesthetic risks, and then the risk of sort of damage to abdominal viscera or the formation of adhesions and things like that. And then if pregnancy does occur, it is more likely to be ectopic. Then emergency contraception. So this is contraception that can be used after an unprotected sexual encounter to reduce the chance of pregnancy. So the options include the morning after pill. So there's 2 morning after pills available. The first one is Levanel, which is 1.5 grams of levonorgestrel. And it's most effective if taken in the first 24 hours after sexual encounter, and cannot be taken later than 72 hours after unprotected sexual intercourse. It works by impairing the function of sperm, and it disrupts the endometrium to reduce the chance of implantation, and if it's taken around the time of ovulation, it can prevent follicular rupture, which prevents ovulation. If someone's taking it, they need to be aware that it can disrupt their subsequent menstrual cycles and cause irregular bleeding, because it's quite a high dose of progestogen. And the second morning after pill that's available is Ella1, so that's ulipristal acetate, and that's a selective progesterone receptor modulator. This one can be used up to 120 hours after the sexual encounter, and it works by delaying ovulation and preventing implantation. And then the third option for emergency contraception is the intrauterine device, so the copper coil. This is the most effective emergency contraceptive, but it's not always acceptable to women, and it's not always as available as a tablet. But it works by preventing implantation. It can be inserted up to 5 days after unprotected sex, or 5 days post expected ovulation, so that potentially gives you even more time to insert it. And that also has the benefit of providing ongoing contraception. And then finally, if you are counselling a patient for emergency contraception, other things that you need to be aware of are if they've had unprotected sex, then you need to offer them an STI screen. You need to think about ongoing contraception for them. And then you need to advise them that if their next period is late, they do need to take a pregnancy test, because none of these are 100% effective. And finally, special groups to think about when you're prescribing contraceptives. So if you're prescribing contraception to adolescents, poor compliance is often a problem in this age group, so a long-acting reversible contraceptive is much more preferable. And then you'd also want to advise them to use a condom for STI protection as well. But you also need to think about the ethics of prescribing contraceptives in the under 16s, and there's a separate mini lecture on child protection, safeguarding and the ethics of contraceptives. In inflammatory bowel disease, there's a high risk that there's malabsorption going on, therefore if they're taking an oral contraceptive it might not get absorbed, so a parenteral contraceptive is likely going to be better, but not Depo-Provera, because they're already at a higher risk of osteoporosis and you don't want to reduce their bone density any further. In breastfeeding women, so if the patient is amenorrheic and exclusively breastfeeding, that is 98% effective as a contraceptive for 6 months postpartum. So if the woman is happy with that, you don't necessarily need to offer alternative contraception. And for the first 21 days postpartum, contraception isn't needed at all, so you don't need emergency contraception either. For around 6 months after birth, you should avoid the combined oral contraceptive if a woman's breastfeeding, because it can reduce milk production, but the progesterone-only contraceptives are acceptable. And the intrauterine device is also an option, so that can be inserted either at the point of C-section or 4 weeks postpartum. And then if you're offering contraception to someone approaching the menopause, they should know that if they're under 50, they should continue contraception for 2 years from their last period to ensure that they don't get pregnant. And if they're over 50, then they only need to continue contraception for 1 year after their last period. So let's just go through some cases briefly. So I'm going to go through the questions here, and then the answers will be on the next slide. So if you want to have a think about the questions before you go to the next slide, then you might want to pause the video. So first of all, Jane is a 26-year-old woman who presents to your GP surgery asking for contraception. So she describes having regular periods, but they're very heavy and very painful. And she does admit that she thinks that she might not get on very well with a pill because she can be forgetful if she has to take tablets regularly. So what contraceptive methods would you offer Jane? And then secondly, Eloise is a 17-year-old woman who presents asking for emergency contraception. So she had unprotected sex 2 days ago and she has no past medical history. So what emergency contraception could you offer Eloise, and what else would you need to consider after emergency contraception has been prescribed? So I'm going to go to the answers now. So in terms of Jane, there's a lot of good options for Jane, and often giving her something like a leaflet which will help her process the information. She can look at the various options available is quite helpful. But from the history, we know that offering her tablets, a pill, isn't going to be a very good option, and we wouldn't offer her the copper coil either because this will make her periods heavier and more painful, which is not what we want. The Mirena would be ideal because that's useful for reducing bleeding and reducing pain, but not all women are happy with that idea. So any other progesterone containing long-acting reversible contraceptive should also help with the pain and the blood loss, so that would be a sensible option, and you can leave that choice to Jane really. And then for Eloise, so Eloise is only 48 hours post unprotected sex, so she is in the time window for Levanel or ulipristal acetate. The choice between them will probably depend on local prescribing guidelines. The copper IUD would also be a good option for her if she's happy for that, and that also has the benefit of providing ongoing contraception. And then in terms of other things you'd consider for Eloise, so we'd advise her to take a pregnancy test if her next period is late, because none of these options are completely effective. And then you'd have a chat with her about ongoing contraception. So a long-acting reversible contraceptive is ideal because it doesn't rely on having to remember to put on a condom or to use a tablet every day, but obviously that's up to her as well. And then you'd offer her an STI screen and advise her to use condoms as well to protect against STIs in future. So these are my references. Thank you very much for listening.